sir. Now the screen is visible.
No, it's visible. Yes, yes. So you can hear my audio, guys. Just tell me in the comment box if you can, if the audio is clear. Mine and Nazima's. Sorry for the delay, and we tried our best, but this software I'm just new to it, and there are always some problem. There are a lot of options. It's a very complicated software, OBS Studio, and it takes time. This is our second stream. Okay, Nazima, you can start now.
Good evening, sir. Good evening, everyone. My name is Nazima Bibi, final year MBBS student, ANIMS. As my friend has presented the case of mitral stenosis with rheumatic heart disease, I would like to highlight the positive point in the history and examination and try to explain each one of them. Let us begin.
So, Nazima, before we go into the anatomy and the detailed explanation, so last time what all we discussed, just tell me the history presentation.
In the history, the
patient had what all complaints?
The patient came with dyspnea and paroxysmal nocturnal dyspnea.
Yes.
And the patient has irregular pulse.
And also shortness of breath and hemoptysis, and history of PND was also there.
Yes, sir.
So we had covered the history part of it, and
part of general examination.
And general examination we had just started. So would you like to just start with the general physical examination, because that is what we have to discuss more. No problem. I know it wasn't your this thing part of your PowerPoint, but I will start. I just need leads, so you say something and then I will tell you, teach you people. So on general physical examination.
Okay, sir. I'll start.
And bring the microphone little close, because somebody is writing that Nazima's pitch is low. Just bring the microphone closer to it.
From the beginning, sir, general examination.
Now it is okay, yeah.
From the beginning, sir.
Yes.
The appearance of the patient is ill-looking. Body build is average. The patient was cooperative, and pallor, icterus, cyanosis was absent. Clubbing was absent. Edema was absent. On examination of the pulse, the rate of the pulse was 78 per minute. Low volume, irregular, with all the peripheral pulse palpable equally.
Okay. So whenever the pulse is irregular, you have to actively look for rheumatic heart disease, and usually 99.9% of the times it is because of mitral stenosis. There is left atrial dilatation, and then the atrium becomes very irritable and it starts fibrillating, and then the pulse becomes irregular. So last time we discussed, like so to check the pulse deficit, you have to keep your hand, you have to keep your fingers on the radial pulse and your stetho on the precordium of the patient, and yeah. So what you will see in pulse deficit? Which one will be more? Heart rate will be more, or the pulse rate will be more?
Heart rate will be.
Yes, heart rate will be more, because
more than 10.
And has an everybody in the Google Meet, they can also answer. They can help Nazima, and you can help me also. So anybody can tell me why there is pulse deficit? Okay, we know there is atrial fibrillation, we know, and if heart rate has to be irregular, the same number of heartbeats should be transmitted to the pulse.
Since the atria is contracting, but that contraction is not adequate, so the pressure impulse is not transmitted to the periphery.
No, you were almost close. So what happens is LV needs a good volume of blood to pump and to make a pulse. Okay, so atrium is just fibrillating, so it's just doing like this, and slowly the blood from the atrium pools into the left ventricle. It goes into the left ventricle through a very tight mitral valve. That's the pathology. Okay, so once there is adequate volume of blood to make a pulse, and then the pulse happens. Okay, so that is why there is pulse deficit. So heart rate is more than the pulse rate, and pulse deficit of more than 10 is usually considered significant, and we have to be very careful with these patients. And most of the times we have to start anticoagulation therapy. You can start warfarin or acetylcholine and monitor the PTINR. Okay, so there was pulse deficit. Then
so the BP of the patient was
so there was, you said there was no pallor. Why did you look for pallor? What This patient is not this is not a case of anemia.
Sir, in case of chronic kidney diseases, then in case of any chronic diseases, anemia can be present.
Uh, this is okay, it's a chronic disease, but it's not supposed to cause anemia, because just now I said we will be putting the patient on warfarin or acetylene anticoagulants. Okay, so sometimes the PTINR is prolonged, it gets more, the blood gets more diluted, so then they will start having microbleeds, maybe from the gut they will be oozing little bit, or maybe they will be having microscopic hematuria, and then the HB starts falling slowly and the patient doesn't even notice. Maybe if the patient is a female patient, she might be menstruating more during her periods, and slowly she becomes anemic. So that part we have to keep in mind if the patient is on anticoagulants, and then we have to check the PTINR. Anyway, once in a month you should check. Whenever the patient comes to you for follow up, you check PTINR, and if it is more than 2.5 the dilution, then control, we should decrease the dose of acetylene. Continue.
BP was over 170 millimeter of mercury in
Okay.
supine position, and
Okay.
the neck veins are neither engorged nor pulsatile.
Okay. Now blood pressure is on the lower side. Okay, 100/60. So whenever there is low BP and a very feeble pulse, and at your level at MBBS level, you will get only mitral stenosis only, this type of patient. Okay, so this is a diagnostic, sort of almost diagnostic. If your patient has very feeble pulse and BP is 90/60, 100/60, that means patient has MS, because the cardiac output is low, the LA can't push the same amount of blood into the LV, and there will be back pressure changes, patient will go into LVF. Okay, so that you have to keep in mind. Can anybody in the audience tell me any other causes of low blood pressure? Nazima, you can also answer. Pallavi.
Aortic stenosis.
Aortic stenosis. Okay. Aortic stenosis. Anybody in the crowd? So see, now again your question has been asked and everybody has a brain block. Okay, so okay, somebody wrote coarctation of aorta. Okay, fine. So coarctation of aorta will be there. There will be difference of BP in the upper limb and the lower limb depending where the coarctation is. Okay. Now hypotension. Now I have asked a question. What are the causes of hypotension? Now you should just relax and think what creates blood pressure, what all mechanism, what all things, what all hormones are involved in maintaining a normal blood pressure. So Nazima, you can tell a little bit.
There is left ventricular failure.
Cardiac output has to be good. One is cardiac output. Okay, so this patient's cardiac output is not good. Okay, some Rohan says it is shock, and Rohit says hypertrophic obstructive cardiomyopathy, and Pranav coarctation of aorta. Okay, so all these things can also cause shock, can cause hypotension. Coarctation of aorta and HOCM as such will not cause hypotension. Okay, HOCM patients usually have hypertension. In fact, their ejection fraction will be very high, and up to from 45 to 70% we consider normal ejection fraction on echocardiography, and if it is more than 70 we have to suspect HOCM. Okay, and they will be having high blood pressure, because you just imagine there is thick myocardium and like bodybuilder, and they will be pumping blood very forcefully, and eventually the heart will fail in HOCM also. But yes, so any other cause? So one is cardiac output, cardiac causes. Okay, so ischemic heart disease and pericardial effusion and mitral stenosis, aortic stenosis, coarctation of aorta. So all these things can cause hypotension. Any other thing which helps in maintenance of normal blood pressure? How can I connect other people in the audio in chat? I can see only Nazima is have green 3 dots. Pallavi, Lokwani, she just Shahid. So and guys, anybody can answer. Okay, it's just a normal class and it's okay. We have to make mistakes and learn, and we are all each other's
There
teachers.
is intravascular volume contraction
Very
in
good.
case of hemorrhage, vomiting.
Very good. So if there is intravascular volume is low and accidents or because of acute gastroenteritis and patient has lost a lot of fluid in cholera and because of any other cause, so they can have low blood pressure. Any other thing that maintains the blood pressure? One is heart, then fluid. Okay, two things more you have to tell me.
Hypothyroidism in myxedema.
Okay, okay, now you are coming to the track. So hypothyroidism, now we are thinking of hormones. Okay, so one hormone is thyroid, TSH. So in hypothyroidism you can have hypotension, and in hypothyroidism hypotension will be because of many causes. Okay, one is low cardiac output, and hypothyroidism can cause pericardial effusion, and one more thing with what hypotension does is it causes hyponatremia. In fact, if you see any patient in you are doing rounds and you see some patients, your patient's sodium is low, you should think of hypothyroidism. Okay, and anything else that controls sodium?
Addison's disease.
Very good. Okay, this is a topic very close to my heart. All of you know in clinics I teach you so much on Addison's. So if the patient has low blood pressure, you have to think of Addison's, and many times the patients with Addison's, they will be living a normal life, but when they are exposed to stress, then their adrenal glands can't pump more cortisol, and then they will go into adrenal crisis. Okay, and these patients, they will present with vague symptoms, and if you are not actively thinking of Addison's, you will lose your patient. You will be over treating with different things which the patient does not need, and in Addison's they will have a poor their ejection fraction will be low, and they have a tubular heart, small heart, and the creases will be very dark and pigmented, and this border of the hand, this will be very dark and this will be very light. Okay, so these things you have to make a note of, and their complaints will be very non-specific. They will come with GI upset, pain in the abdomen, and colicky pain, malaise, fever, lethargy, and irritability, and you will almost feel tempted to write Alprex and send the patient home. And if the blood pressure is low and sodium is low, you have to check the serum cortisol levels. Okay, so you can do 8 am serum cortisol and 4 pm serum cortisol levels, and after that we can do further tests to diagnose Addison's. And their cardiac reserve is not good. So if BP is 90/60, most of the Addisonian patients, their BP will be 90/60, 80/60, 60/40, and they'll be normal, they'll be walking around normal, and don't start pumping blood, pumping IV fluids, that patient is in shock, let's give IV fluids, and don't start drips and push the patient into cardiac failure. Okay, so you have to correct the sodium, and you have to give steroids, and hydrocortisone you can give, and that will increase the vasomotor tone. So from this tone, from steroids, so adrenal gland and thyroid, they control the sodium levels. Okay, so if sodium is low, you have to think of these things, and in Addison's sometimes they will have hyperkalemia also, and sometimes you will start the patient on dopamine, dobutamine infusion for bringing up the blood pressure. You might even start NORAD and infusion, and still the BP does not come up. That is because the cortisol level is low, and in the absence of steroids, in the absence of cortisol, the tone of the vascular bed, the arteries, it will not be normal, it will be low only. So adrenaline, noradrenaline, dopamine, dobutamine, they will not work, and patient shock will persist. So you have to add corticosteroids, and then the BP will come up. So this is a take home message. If you see a patient, if you have a patient after giving a fluid challenge test and after starting different vasopressors, the BP is not coming up, you have to give steroids. Okay, and then the blood pressure will come up. Okay, so this was something you people have learned today. And what else will be characteristic of blood pressure in Addison's? Anything else in the blood pressure you will check, Nazima? You have to look for orthostatic hypotension. Okay, so if sodium is low, these patients will have orthostatic hypotension, and this is almost diagnostic. So if sodium is low and you check for orthostatic hypotension and the vasomotor tone is less, they will have orthostatic hypotension. Then think of Addison's primarily, and also rule out hypothyroidism. And remember, sometimes in hypothyroidism, when the patient is in myxedema coma, they will not come out of it until unless you give and myxedema, coma and hyponatremia. They will not come out until unless you give eltroxin IV and corticosteroids, and sometimes it is required, both of them are required, otherwise the patient won't wake up. Okay, continue.
JVP was not elevated.
JVP was not elevated. So last time we discussed that JVP and differences between SVC obstruction and raised JVP, है ना? So that we won't go into that again. Can anybody tell me the different waves of JVP and why they are formed? Anybody in the audience? Shahir, Lokvani, Pallavi, Sonali, I can see you people, please answer. Haan, Nazima?
Sir, A wave is due to effective right atrial contraction.
Good. A is A for A for atrium, atrial contraction.
Then X descent is due to during ventricular systole. During this, there is atrial relaxation.
And what? And C wave, A, C, V. These are the positive waves.
C wave is due to there is during isovolumetric contraction phase. There is upward bulge of tricuspid.
Very good. Okay, very good. So the tricuspid valve is closed, and the three cusps are like this, and the RV starts contracting, and the cusps are pushed into the RA. So that causes a small C wave. And V wave?
V wave is due to rise in right atrial pressure due to right atrial filling.
Okay, so we are discussing this cardiac case. So in this patient, like patient is having atrial fibrillation. So which wave will be affected mainly?
Absent A wave.
Very good. So A wave might be absent, and even sometimes in complete heart block you might see canon A waves. So suddenly you will see a good RV impulse transmitted across an open tricuspid valve into the internal jugular vein. Okay. Continue.
Sir, examination of cardiovascular system then. On inspection, there is no deformity of the precordium. There is no precordial bulge.
Why would you look for deformity? Guys, anybody can answer. Please answer in the comment box, and the 4 people who are connected on Google Meet, please answer. Otherwise,
in case of long-standing heart disease, there can be bulging of the precordium.
Especially in congenital heart diseases.
Congenital heart disease.
Because that time the rib cage is very flexible, and with each pulse it is bulging out, and there is cardiomegaly, and then the rib structure takes that form only. Okay, continue.
Yes. The apex impulse is visible at the left fifth intercostal space. Then, sir, on palpation,
no, you have to tell more about. Okay, continue. Tell me more about apex beat.
The apex beat is present in the left fifth intercostal space, half inch inside the midclavicular line.
You can just say medial to midclavicular line,
medial to midclavicular line, and is tapping in character.
Okay, tapping. And from the center, how many centimeters roughly? Chalo, continue. So it is medial to midclavicular line. So, and it is in the fifth intercostal space. So what does it mean? There is no LV enlargement. Okay, this patient probably has not developed long-standing MR, because these rheumatic heart disease patients, they will present with stenotic lesions. Okay, there is hardly any pressure in the LV because blood is not coming. So LV is not enlarged. So apex beat is not shifted laterally and downwards. Okay, and continue.
And a diastolic thrill is palpable in the mitral area, which is best felt in the left lateral position and in full expiration, and there is absence of left parasternal heave.
Okay, so probably there is no LV dilatation and there is no MR, and if there is parasternal heave, we have to think of RV enlargement also. Okay, because the back pressure changes in eventually it will affect the RV also. And yesterday we were discussing that LV can cause LV failure can cause right ventricular failure, but there are conditions where right ventricular failure can also cause left ventricular failure. The hypothesis they say is like interventricular septum is the common wall between RV and LV. Okay, so when the RV dilates, it stretches the interventricular septum, and if the LV is little weak, and then the IVS cannot contract because of the dilated RV, so then the LV also starts failing. So that is one explanation. They say why the LV also starts failing in certain patients in whom the RV is like compromised. RV function is compromised. Okay, continue.
Sir, there is palpable pulsation in the pulmonary area.
Okay, so pulmonary area where, which intercostal space, and on the left side, right side, where?
Second left intercostal space.
Second left intercostal space. So how will you look for that?
It's a palpable pulsation.
You will palpate it with your tip of your fingers. Okay.
Sir, on auscultation of the mitral area, the first heart sound is short, sharp and accentuated. The second heart sound is audible. Opening snap is heard just after S2.
Okay.
There is a low-pitched mid-diastolic murmur of
So,
grade 4 intensity.
okay, so why is opening snap there? How is opening snap caused? What causes opening snap?
Opening snap is caused due to sudden stoppage of movement of the valve.
The valves are calcific, okay, and they are not very flexible, they are not very pliable, so they cannot contract suddenly with low pressures build up. So the pressure in the LV will keep on building, but suddenly they will close. Okay, like that. So opening snap, suddenly they open. So that is because of calcific valves. And after some time, when the patient's MS deteriorates, this opening snap will vanish. So this also you have to keep in mind. So if there is no opening snap, it could be just a mild MS or a very severe MS.
There is a low pitch mid diastolic rumbling murmur of grade 4 intensity in the mitral area, and best heard in left lateral position at the height of expiration.
So how you will differentiate between left sided murmurs and right sided murmurs?
De Carvalho's phenomena, right sided murmur increases on inspiration.
And why does that happen? Anybody in the crowd? Why right sided murmurs they will increase, or do you not agree with Nazima and you think left heart murmurs will increase on deep inspiration?
During inspiration, due to negative intrathoracic pressure, there is increased venous return.
Very
There is
good.
increased flow of blood across the valve. This increases the right sided murmur.
All the cranial blood vessels, blood in the neck veins and all, it is all sucked into the RV. Okay, so that is the explanation. Yes, you are right. And continue. So right sided murmurs they will increase on deep inspiration, left sided murmurs they will decrease on deep inspiration.
So then examination of there is absence of any split, rub or murmur over other areas.
So why did you think about split, and what is the importance of A2P2 split? Any condition you know in which the split, like if you can hear the split and you look for certain quality of split and you can say this patient has this disease. Anybody in the crowd? Some congenital heart disease. I am giving you a hint.
In atrial septal defect,
Very good.
the split will be wide and fixed.
It is a wide and fixed split in AST. Okay. ठीक है, चलो आगे.
Sir, an examination of the other system revealed no abnormalities. There is
So other abnormalities like what? So what did you look in the respiratory system? What did you look in the abdominal system? So 2-3 things, just 1 or 2 lines about each system.
There is no other adventitious sound in the respiratory system.
Like?
And like crackles.
Okay, there are no crackles. So where will you look for crackles if there is failure? If you're
Basal crack.
basal crabs, posterior basal crabs. Okay. Okay.
And there is no hepatomegaly or ascites.
Very good. There is no hepatomegaly. There is no splenomegaly. There is no ascites, and there is no pedal edema probably. है ना? ठीक है. चलो. Next.
Diagnosis.
Hmm.
Diagnosis based on the symptoms, since the patient presented with breathlessness, effort intolerance for last 2 months, cough with hemoptysis for last 1 month, attacks of paroxysmal nocturnal dyspnea since last 2 weeks, and there was also a past history of rheumatic fever.
So first you have to give me differential diagnosis, and then you have to give me probable diagnosis. At your level, we expect this much, and little bit about treatment. So tell me one or two causes of the patient's complaints which could have caused. So one is rheumatic valvular heart disease.
Yes.
So with that you have to tell me which valve is involved predominantly, and any other valve is involved. It is compensated, decompensated.
Since there is only a mid-diastolic murmur heard at the apex, so only mitral valve is involved.
Okay. And P2 was loud, and you could feel the P2 also.
Yes.
So there is pulmonary artery hypertension, and patient has PND also. So he is decompensated. He decompensates in the night. So it's a decompensated cardiac failure, and with medications he might become okay or might not become okay. Okay. So any other condition other than rheumatic valvular heart disease which might cause these symptoms?
Left atrial myxoma can cause a mid-diastolic murmur.
Okay. Whatever you have answered till now, this is enough to get you across the line in the exam. That is very good. Now you have to score more marks. This much of answering is okay, like in the exam. One is left atrial myxoma.
Then atrial ball valve thrombus.
Okay.
These are all the DDs for mid-diastolic murmur.
Okay. So how you will manage this patient? So when we say management involves investigations and treatment.
We'll move forward with baseline investigations like complete blood count, serum electrolyte. Then a ECG can be done, showing it may show a right atrial enlargement.
Right atrial enlargement.
And features of right ventricular hypertrophy.
So why should there be right atrial enlargement? Patient has mitral stenosis.
Left atrial enlargement.
Patient should have left atrial enlargement. Hai na? So which is the best lead to look for these changes in P wave in ECG? Guys, in the comments please tell me how many of you will be attending the ECG live streams, because your classes have started from tomorrow onwards. They will be starting, and if you I know it will be a hectic schedule for you, but we will fix time and start ECG lectures. I will be streaming, and you people can just listen and clarify your queries. So tell me in the comment box how many of you will attend, and you can also tell Tandra also how many of you are willing to attend. So then we will fix a schedule. What is a convenient time for you? 8 o'clock I think is okay for should be okay for everybody. हाँ Nazima.
In lead 2 and
in lead 2 and V1.
And P mitral will be seen, wide notch.
So in lead 2 what happens is, lead 2 the vectors are directed towards, electrical vector is totally towards lead 2. So you will get a very nice P wave, very nice R complex, and very nice T wave. So the complexes are good volumes. That is why we look in lead 2 for P wave also. And in V1 the P wave is biphasic. So the positive component is right atrium, then isoelectric line comes, then the negative component, that is the left atrium. So you can easily see clearly in V1 whether the positive component is more or the negative component is more, or whether the positive component has overtaken the negative or negative has overtaken the positive component. So it's the best lead to see the left atrial or right atrial dilatation. What else can you see on ECG in these patients?
Features of left ventricular hypertrophy, right ventricular hypertrophy.
Right ventricular hypertrophy. Okay, chalo. Something more important than that. This patient has it.
Atrial fibrillation.
Very
So
good.
the rhythm.
Atrial fibrillation. So you okay. So atrial fibrillation. Now in ECG, you know how to check the heart rate, or we'll continue in the next class, when we take lectures on ECG. Okay. So you can anyway go. All of you can go back and check how to calculate heart rate in atrial fibrillation. This is a very important question, and all of you should know, because RR interval is always irregular. So how you will check the heart rate in atrial fibrillation? Chalo आगे.
Sir, on chest X-ray, there can be signs depicting the left atrial enlargement. Like there will be straightening of the left heart border, that is mitralization of the left heart border.
Okay.
There can be double right heart margins or double shadow appearance of the right heart margin.
So why does that happen? That double concavity, that shadow on the right side?
Due to the outer and the upper border will be due to left atrium, and the inner
Very
and
good.
the lower border
Because of the left atrial dilatation. So if the left atrium is so dilated, these patients may complain of GI complaints also, the difficulty in swallowing, difficulty in deglutition, and things like that. Okay, so even GI history is important in cardiac patients, so you have to take that also. And sometimes because of cardiac failure, the intestine is congested and they will be having weak peristalsis. They might come with bloating, distension, and constipation, and that is not because of something else, it is just because of cardiac failure. Similarly, like same sort of thing you will see in pregnancy. In late pregnancy, the progesterone levels are very high, and then patients, they will have congestion of the intestinal mucosa, and then they start having constipation. Continue.
There can be features of pulmonary venous hypertension, like prominence of upper lobe veins, curly A and curly B lines. Curly A line are straight lines seen near the hilum, and curly B lines are horizontal lines seen in the costochronic angle. There can be bilateral perihilar opacity, which fades towards the periphery, known as bat swing sign.
Okay, good.
Then an echocardiography can be done.
Yeah, on echo, what you will see?
Mitral stenosis of the mitral valve.
Calcification you can see, and stenosis you can see, and you can check the mitral valve area. You can see the ejection fraction also, because a cardiac patient, a rheumatic heart disease patient, might also be having poor contractility. IVS might be contracting less, or might be having coexisting ischemic heart disease also. So when you do echo, we look for everything. Left atrium will be dilated. You might see the fibrillation also, and you might see LA clot, LV clot, things like that, vegetations on echo. Okay.
A trans-esophageal echocardiograph can also be done to look for left atrial clot.
Okay, good, very good.
For treatment, firstly, medical management. Treatment of atrial fibrillation need to be done with anticoagulants, and the rate, and for the high rate, digoxin, verapamil, beta blockers, or if unresponsive, cardioversion can be tried.
For atrial fibrillation, you want to do cardioversion. If the patient is awake, so because it's a lot of current, 360 joules is a lot of current, so how you will give DC shock, and it will be a synchronized DC shock or asynchronized DC shock? It will be a synchronized DC shock, because the QRS is not deformed. You are getting a very nice R wave, and the machine will sense the R wave peak, and then it will fire. and don't go with the for very high joules. Okay, don't go for 360 joules. Just tell the patient ki your heart is having some problem, so I will give you a small shock, so just give it with 40 joules or 60 joules, that is enough. But if it's a VT, if it's a ventricular tachycardia, the QRS you will not see. Okay, QRS is totally deformed and the machine won't be able to sense the R wave peak, and in that case you give a asynchronized DC shock. You will just fire, and sometimes you will get a flat line after you give the DC. Even the VT stops from showing, but there is a flat line. So just continue with the CPR, charge the paddles again, give once more, and during that time you can load Amiodarone, and you can give 150 milligram bolus IV, and after that you continue with the CPR and give the DC again. And many times the patient's heart becomes susceptible to the DC after giving Amiodarone. Okay, so you will anticoagulate also?
Yes, sir.
So what you want to give, Nazima, for anticoagulation?
Warfarin.
Warfarin you can give. Anybody? Anybody in the comments box? Any other drug? I have already spoken 2-3 times in this lecture. Acetron. Okay, continue.
Then if the patient has right ventricular failure, then that need to be managed.
Okay, so then digoxin. Digoxin is a very important drug. These days people are they don't like to give digoxin, but digoxin is a very important drug. Okay, and it is very good drug, and if you want to control the AV node and you want to control the ventricular rate and the patient's BP is low, this is one of the best drugs, time tested drug, and don't be afraid to use it. And because most of the other drugs which you will be giving for controlling the ventricular rate, they will cause some fall in blood pressure. Okay, but digoxin will be positive inotropic, negative chronotropic, and it will decrease the ventricular rate, it will increase the refractive period of the AV node, and it will not bring down the BP, it might help in bringing up the BP. Okay, so you can give digoxin. And also digoxin is pro-fibrillatory. Okay, now I know you will say, ki, sir, we are giving for atrial fibrillation. Yes, if there is atrial flutter, it will convert atrial flutter, more dangerous atrial flutter, into atrial fibrillation, and atrial fibrillation is more better controllable, treatable. Okay, so anything else? So this
diuretics for heart failure and ACE inhibitors can be added.
Okay,
for all patients.
these you can add. And one more thing I forgot, whenever you give digoxin, always monitor the potassium levels, because if the potassium level is low, it can precipitate digitalis toxicity. So I usually give syrup KCl 2 teaspoons to the patient whom I put on lifelong digoxin. Or you can tell the patient to take 1 banana or 2 bananas every day, the patient is not a diabetic, or have coconut water. These are very rich in potassium and one of the best nutrition, and they're tasty. And syrup KCl is it has a very awful taste, it is very bitter and you almost feel like puking. Okay, any next, anything else?
Prophylaxis for infective endocarditis is not usually given to the patient unless the patient require mitral valve replacement, or if the patient has previous episode of endocarditis.
Okay, so yeah, this is a debatable area, so I will leave it at that only. For whom to give prophylaxis and for how long? I usually give for at least up to 40 years I give, and some people give it for 25 years, and it is debatable. And one thing you have to remember is what type of lesions you will see in infective endocarditis. How are they different from lesions of rheumatic heart disease in mitral stenosis? I have told the answer actually.
The lesions will be more.
Infective endocarditis will cause regurgitant lesions. Okay, MS will cause stenotic lesions. So if you are hearing a MR murmur, then in a MS patient you are hearing a MR murmur, there could be two things: either the MS is very severe and the valve is not moving at all, and there is a MR also which has started. So the same patient who has mitral stenosis will develop MR also. The other thing is infective endocarditis. It will attack the diseased valve and it will cause vegetations, and then the MR starts. Okay, so any other condition where MR you can see and MR can improve after some time? Today you are hearing MR murmur and afterwards you are not hearing MR murmur. If there is severe left ventricular failure and dilatation. Okay, so this is the LV and it has dilated. So this is the mitral annulus. So the annulus also widens as the LV is expanding. So then functional MR starts. So as you give diuretics and digoxin and other things, the LV size cavity comes to normal, and the murmur, that MR thing, annulus goes inside, and then the murmur stops. MR murmur stops. Next, anything else?
Surgical interventions, like
Yes.
most commonly done are percutaneous balloon valvuloplasty.
Okay, so first we should go for valvotomies. Okay, so mitral valve balloon valvotomies. So they are very safe procedures sort of, and whenever you do mitral valvotomy, it will give you the patient a MR also, because you are dilating the calcific valve. Okay, and if you do once balloon mitral valvotomy, the effects might last for 5 years, 7 years, 10 years, and after that eventually the patient will need mitral valve replacement, and then you have to, second time you should replace the valve and put a nice prosthetic valve and put the patient on acetylene or some other anticoagulant.
Other procedures like closed mitral commissurotomy or open mitral commissurotomy can be done,
Yeah,
or mitral valve replacement can be done.
yeah,
Either mechanical or prosthetic valves can be used.
yeah, good.
Mechanical or bioprosthetic valves can be used.
Okay, good. Okay, so your presentation is over.
Yes, sir.
Okay, so today was good, like good you presented, and this was probably not part of your slides also, and you answered very nicely and confidently. So guys, keep it up, and thanks for coming for the stream, and please tell me whether you want me to take more lectures on ECG and any other bedside clinics online. If you want, we can have it. Thank you for coming.
Thank you, sir.
Thank you. Bye bye.